Hello, everyone. Good morning, good afternoon, good evening, depending on where you are in the world. First of all, thank you to the American Academy of Oral Surgery for this kind invitation. I feel very honored to be here speaking with you today. And my topic for today will be new trends in oral surgery. So let's start where I am from. So I'm from a beautiful country in Europe, near the sea, that has beautiful castles, landscapes, beaches, and a lot of tradition. And if you don't know where already what is my country, you will know in the next slide for sure. It's the country of the best player, the best football player in the world, Cristiano Ronaldo. And of course, I'm from Portugal, and we are also European champions of football. And I'm from a city in the north called Oporto because of Oporto wine. And it's a very beautiful city with a lot of colors and a lot of wine tradition. And you can visit because it's really, really beautiful and was considered one of the best travel destinations in Europe in the last years. And I started where I'm from. Now I'm going to talk a little bit about who I am. I'm doing dentistry, namely surgery and implantology for the past 18 years. I'm very passionate about my profession. And I'm a woman in a man's world because I'm an oral surgeon. And this is a little video showing a little bit about who I am and my story and my titles.
So I want you to please help me welcome the next speaker from Portugal, Raquel Zita.
Unfortunately, this year was a strange year. I didn't travel too much because of COVID-19. I hope next year we will return to our normal education programs. So just to start, I have some collaborations with universities, with education platforms, with some brands. And I would like to tell that I always choose the brands, the education platforms, the universities, the ones that I think are the best interest for my patients and for me. So just to clarify that I try to use the best product, not for only for me, but also for my patients. And today I will try to cover some topics. It's a little bit difficult to cover it in 40 minutes, but I will try. And I will try to talk about some new trends in oral surgery, namely in advanced implantology. I will talk about ISQ, implant stability caution, low-level laser therapy, piezo surgery, the CBCT, the PRF, plasma-rich fibrin, the palatal approach for implant placement in the maxilla, the T-scan, that is a digital occlusion assessment, and immediate loading, and how can we do immediate loading with some guidelines. And where should we start? We always should start going back to the basics. And going back to the basics, we have to define that we have three different types of loading protocols: immediate, early, and delay loading. And basically, the three most important criteria to take this decision between the three will be the ISQ, that is implant stability quotient, the torque, and the bone density. And we know by the ITI consensus that immediate loading is not only in the day or in the hour of surgery. It means it, it has loading until 48 to 72 hours after placement. And then early 48 to 12 weeks, and delay after 3 or more months. And we know that the torque measures the rotational stability, and we only measure it once. So it's not a lot of information. But the ISQ, we can measure it several times. We can measure it at the implant placement and then after to do a follow-up. And we can measure the axial stability, that is a different measure from the torque, and we can measure it several times so we can do the follow-up. So nowadays we know that the ISQ is more important to take the decision about immediate loading than the torque. And ISQ is a scale of stability. It goes from 1 to 100 and uses RFA, that is resonance frequency analysis. And the normal stability will be between 55 and 85 ISQ. And there's some apparatus that mainly were developed by Ostel, that is the brand that developed this apparatus. And to measure the ISQ, we can use a smart peg, that is a tip that is specific for each brand of implants, or at least each connection. And we measure the vibrational stability of the implant in 2 different directions. And the normal behavior of the ISQ with time will be having a download between 3 to 4 weeks and then having an upload again. So, or we do immediate loading, or we wait at least ideally 6 weeks, because in the meanwhile we have a break of stability, so is the worst part to do the loading. But we are very curious, and we did some research in our university, and we choose the posterior maxilla, that is the worst case scenario, because we have low quantity and low quality of the bone. And even to upgrade the study, we did 3 groups: one with hilt bone, one with post-extraction and immediate regeneration, and another one with sinus lifts. And we compare this evolution in these 3 groups, and what we found was very interesting because of the type of implants that we were using in the study. This is a human study, it's a clinical study in the posterior maxilla, and we had no breakdown during the healing time in the posterior maxilla in the 3 groups. Of course, this is an exception because it's only valuable for this type of implants. So it's better to consider that the implants have a normal behavior, that they will have a breakdown on the primary stability between 3 and 4 weeks, and then it will go up again, because we have the mechanical stability, and then we'll have the biological stability, and that transition will have a break. But why do we need this kind of guidelines? It's very important, like a traffic light. If we had the red light, it means it's low stability, lower than 60, and it means that we shouldn't do immediate loading. We shouldn't put a healing abutment. We should put a cover screw, and we should wait. If we have a medium stability, that is the yellow light, we have between 60 and 70 of ISQ, and we can put basically a healing abutment and avoid a second stage surgery. And if we have a high stability over than 70, and in single over than 72, we can have the green light to do immediate loading. This has articles, about 1,000 articles about this topic that were gathered together to do these guidelines. So it's not only my experience, it's the experience of a lot of clinicians and researchers. So basically, when we're talking about single implants, if we have torque lower than 30 and ISQ lower than 60, ideally you should put cover screw. If we have torque more than 30 but less than 45, ISQ between 60 and 70, we can put a healing abutment. And if we have torque more than 45 and ISQ more than 72 in a single implant, we can do immediate loading or restoration with no problem. But if we talk about several implants that are splinted together, the values are a little bit different, because the implants are helping each other. So we have like the example of the ballerinas. So the thresholds are a little bit less. So instead of 30, the threshold, the minimum will be 25, And the difference will be the maximum torque will be for having a immediate loading. When you have a splinted implant, should be torque more than 40 and ISQ more than 70. So we uh, the threshold was a little bit down than regarding single implants. And about the bone density, we know that we have the old classifications, the old school, what I call the old school classifications that are very good, but they don't give me a lot of information before I go to surgery. So nowadays, I prefer to use what I call the new school's classifications that are the bone density that we can measure pre-operatively on the study of the TC or the CBCT. And we have a radiological misclassification in house field units that can go from D1 to D5. So before going to surgery, we can anticipate the type of bone density that we will have. And also in our faculty, we did some research trying to find some correlation between the bone density before going to surgery in the CBCT, the ISQ in the implant placement, and the torque in the implant placement. And we found this equation by linear regression that could give us the ISQ if we have the torque, but only in 74% of the cases. And this is only valued to this type of implant that is knife thread implants. But it's curious, this kind of correlation. And it was published in 2014. And this is a simple classification of insufficient ridges and how I take the decisions what type of the treatment I'm going to do. Basically, if I have a socket, I have three chances or three ways of dealing with it. Immediate placement, socket preservation, or waiting for the healing. The low ridge, we have several ways of dealing with it, namely short implants, tilted implants, GBR blocks, and the techniques that regarding the inferior alveolar nerve, the trispas, the lateralization, and the transposition. Regarding the thin ridge, we have several techniques, namely ridge flip, GBR, like the sausage technique, for instance, the tie mesh, and the mini implants. And regarding the sinus, we can avoid going by tilted implants or going for anchorage in the zygomatic, but we can also do some grafts in the sinus by pressor or lateral approach. Now that we got to the basics, now the show must go on, and let's go for clinical cases and to show the application and some of the topics that I told that I'm going to talk. So this case is a case of a lot of atrophy in the upper maxilla, a lady that is 70 years old with osteoporosis, and she didn't want to do very severe procedures with bone grafts. So in this case, we thought about doing an overdenture on 4 mini implants with palatal approach, and I'm going to explain what is palatal approach. As you can see here, when we have a thin ridge, less than 2 millimeters, if you go with a burr on the ridge, it will destroy the ridge in the first burr. So we go palatal, and not only in the anterior zone, but sometimes in the posterior zone, like in this case. So as you can see here, after we put the implants down, most of the time we don't have any surface that is visible. If we have, we can also do some regeneration by the palatal side, but we maintain the focal side. That is the one that is more difficult to maintain and to do regeneration. And these are mini implants by Bredent, as you can see here. And then after the healing, we do second stage surgery in this case because the torque was quite low. So we did cover screws, and then healing abutments, impression with open tray, and the overdenture. Simple case, as you can see, before and after. And we also published about this palatal approach, this technique that I used for many years, and other authors also already talked about in 2 months ago at the Eddy Journal, and you can consult this article, but it's a different case. Now let's talk about a case that we are going to do immediate loading, and we're going to apply also antimicrobial photodynamic therapy with low-level laser therapy. I'm going to explain how and why. And this is the initial status. As you can see, we have a defect on the area of 21, 22 tooth because we had a cyst. So here I'm going to explain how I'm using the low-level laser therapy, not only the red laser as anti-inflammatory or antimicrobial when I use with a specific dye, methyl-toluene, or sometimes I use the infrared laser as biostimulation, but more for transposition and naturalization. And we can use this low-level laser therapy is a diode laser of 660 and 780, so red and infrared, at several applications. But to be used as antimicrobial photodynamic therapy, we need to use together a dye, that's a blue dye, that is from elbow blue from Brennan, that is methyl-toluene. As you can see here, I'm applying the dye. It should stay for 1 minute. Then we rinse with saline. And then we apply the laser or the red laser that will burst the bacteria because it will cause oxyreduction reaction on the wall of the bacteria that is stained with the blue dye. Here we are using like tilted implants that is well described in the literature. This one will be quite tilted, more than a little bit, slightly more than 45. Of course, you have to see if the brand has the right abutments to correct this. And in the anterior zone, we are going to use one place as post-extractional and the other place as palatal approach, as I've told before. So you can see here the implants, long implants, and the good stability. So now we are measuring the ISQ in all of them, and you can see also high stability. And now we are doing some grafts with xenograft, in this case osteobiol by Technoos. This is a porcine orange with some collagen membranes. And we are using the final abutments, the multi-unit abutments, if possible. In the lower jaw, we are extracting. 2 of them will be post-extractional, 2 of them will be in healed sites. Also long implants, good stability with torque and ISQ. And as you can see here, we have the right condition for immediate loading. So we are putting also the final abutments. This concept is called one abutment, one time concept to train the bone and save the tissue. And we are doing a traditional pickup with some Ravaderm and with the lab technician helping to pick up this with acrylic, and goes to the lab to be polished and finished. And the patient comes in the morning and in the afternoon he goes with the provisionals in acrylic. You can see here the x-ray in the lower jaw with parallel implants, in the upper jaw with tilted implants, and in this case very tilted because the sinus was quite horizontal, so it was not possible to do more vertical implants in the distal ones. And now let's go to a case a little bit different from the lower jaw, that we're going to talk a little bit about transposition of inferior alveolar nerve, and we are going to use PRF as a biostimulation, and also the low-level laser therapy, but in this case with a different purpose. And it's more to be biostimulation of the healing and also as anti-inflammatory. And this case is a female 6-year-old, healthy, but had prior implant failures. And this is a funny case because it's a referred case by a doctor from Italy, Dr. Pierluigi Casella, that took the patient to Porto to do the surgery, and then he did the rehabilitation in Italy. And in this case, when the patient came to Porto, she already had lost the distal implant on the fourth quadrant, and the mesial one was with a bone loss, a big bone loss, and the position was not so adequate. It was a little bit vestibular, so our option was to explant that implant. And then we did some visualizations, and I'm going to show a little bit more about this technique. And also we use a way of checking the occlusion that is called T-scan. That is a digital way of assessing the occlusion, because in this kind of very technical work, it's very important to have the right occlusion to maintain the hard work that we did. Let's do some generic considerations about inferior alveolar nerve. Everyone knows that is a sensitive nerve, so if the patient will have some problem after the surgery, it will be something sensitive, not motor. Okay, we don't have any motor component on the nerve, and has around 3 to 4 millimeters of diameter, has 3D obliquous trajectory from posterior to anterior, and we have different techniques to mobilize the nerve with high success. Namely the transposition, that we cut the incisive part of the nerve and move the mental foramina distally, or the lateralization, that we only pull the nerve laterally, we put the implants and put the nerve back. And each technique has its own indications, and nowadays I'm doing more transpositions than naturalizations, because normally the post-op it's quite faster, and the healing and the recovery of the paresthesia is better. So this technique has a specific indication, like all the techniques, and we have to have at least 8 millimeters of total posterior mandibular height, not on the top of the canal, but between the upper jaw and the lower jaw. Okay, because if we have less than that, the risk of fracturing the mandible during the procedure is high. So be aware that if you have a very, very atrophic mandible, less than, for instance, 6 or 5, don't do these procedures, because they are going to open a window laterally, and the risk of fracturing the mandible is high. And we have, of course, to have severe atrophy of the mandible. What is in the literature is less than 9 millimeters on the top. But to be honest, with 9 millimeters, I do short implants. I prefer to do short implants that have less complications and less risk. So if I have 9, I will put implants of 7. But if I have 3 or 4, okay, in these situations, I will do lateralization or transposition, because in the posterior mandible, it's very difficult to grow in high the bone. And piezo surgery, I think, for me, it's the only situation that I think is really mandatory. Because in other situations, I think we can do the procedures with burrs or with other techniques, the sinus, the harvest. Of course, if you have a piezo, you can use a piezo because it's quite good. But in this particular situation, I think it's mandatory to use piezo surgery, because we know piezo cuts the bone but doesn't cut the soft tissue. So it doesn't cut the nerve. In the case of the transposition, the technique that I was explaining, the nerve should be cutted in the incisive part, not in the alveolar inferior nerve part, not in the mental part, but in the incisive part that goes to the other side. And it should be 3 millimeter mesial to the mental nerve. I'm going to explain, I'm going to show a clinical case. And to revert the temporary paresthesia that always happens, but normally it goes away in about 2 months, sometimes even less. I use for protocol the corticotherapy during the surgery and some days after, to avoid the swelling and the compression of the nerve. I use PRF, plasma-rich fibrin, to stimulate the nerve and to involve the nerve to create a new fascia. I use vitamin B complex 1, 6, and 12 as biostimulation. And ideally, I should do this for 2 months. And I use low-level laser therapy also as a biostimulation. And in this case, I use the red and infrared, and the infrared is the most adequate laser for this kind of situation. So this is the initial status of the patient. As I told, the implant mesial on the fourth quadrant was with some bone loss and not in the ideal position. So our idea was to retrieve that implant. So we did explantation of that implant. As you can see here, it was slightly vestibular. And then we localized the nerve. And sometimes I use pencil, a traditional pencil. You can see here what is in gray is a traditional pencil that went to the autoclave, so it's sterilized. And I use in the surgery to do the drawings, to mark where the assistant should put the retractors or to signalize or to draw the wall. And it's quite easier for me and for the people that are working with me to see better what we are doing. And we are individualizing the nerve. As you can see, we have a fascia around the nerve. The nerve is composed about 5 to 8 small fillets, and then some lymphatics and some fascia around. You can see here we are using implant retriever to remove the old implants that have it's a MK4 brand mark, probably with more than 25 years in function, and we are removing. And you can see here the site that was removed. And in this case, I'm going also to use the low-level laser therapy as antimicrobial photodynamic therapy with the dye, the blue dye. So as I explained before, I put the blue dye on place. I wait for 1 minute, okay, for spots, and then I rinse with saline, and then I use the protocol with the red laser, the 660 nanometer laser, and I will go to decontaminate the place that I removed the old implant. I also do this in post-extractional or in infected sites to be sure that I don't have any infection or any bacteria in that place before I will reput my implants. Can he see here? We are individualizing the nerve down, and here I'm designing the wall to have access to the inferior nerve and to the incisive part of the nerve inside the mandible. And what I'm using here, this rubber, you can use specific rubbers from cardiovascular surgery, or you can use the upper part of the sterilized glove, and you can cut that part and use that to retract the nerve without pulling too much. Of course, you have to have a trained trained team to do the surgery with you, the assistants, the doctors, because they can't pull too much. But the glove, I think, is a good trick to pull without being too strong. And then we are opening first the incisive part, because here we are doing with doing a transposition, so we need to cut the incisive part of the nerve. So first we go for the incisive part, and we are opening, and then we expose the incisive nerve. And then we are opening distally the window, and because we want to expose the inferior nerve, the one that we want to mobilize to do the transposition to put the implants, and then to put the new mental foramina in a different position, in this case, of course, more distally. As you can see here, after removing the cortical, we have some medullary, and this medullary, sometimes you have to remove it with a piezo or gently. And we are using, in this case, part of the mental wall of the mental foramina to maintain, okay, and to slide distally to block it distally. So I'm maintaining part of the bone that was around the mental nerve to slide to the nerve and go put it distally and block it. Not always is possible. Sometimes I remove it all, but when possible, it's preferable to maintain some bone around And if it's possible to block it distally, that is perfect. As you can see here, we are now with the incisive part coated with the inferior vela nerve already out of the canal, and we have the part of the bone that is blocking, or we are trying to block it distally. As you can see here, it's quite visible. And now we are preparing the sockets for the implant placement. Okay. In this case, we are putting 2 more implants extra, the one that is in the anterior part. As you can see here, we have the distal implants in place, and we can see there the incisive part cutted. You can see here an occlusion view. In the anterior implant, we try to correct a little bit the angulation. It was not so easy because the explantation was, the older implant was a little bit vestibular, but we tried to correct, and we could correct it a little bit. And you can see here, in this case, because we had a good primary stability, technically, even we had the conditions to do immediate loading, but to be honest, I think these cases are not the right cases to do immediate loading, because the risk of fracturing the mandible is high. So that's why in this case, I don't follow the rules. I follow my clinical sense, and I think it's a risky case, so I prefer to put only healing abutments and avoid a second stage surgery. And you can see here we are blocking the part of the bone distally, and you can see there the nerve and the part that was cut in the incisive part with the healing abutments. And as I told before, I'm using PRF in this technique. I use PRF in several techniques, but in this particular situation, we can use it as APRF or IPRF. A means advanced PRF and I injectable PRF. In this case, it's more logical to use the APRF as a membrane to involve the nerve, but also you can use as IPRF to mix, or with xenograft or with autologous bone in the bone mill. That will be the case, to then put the bone again in place. As you can see, the APRF you can use as plug or membranes, and the IPRF as injectable or as sticky bone. And you can see here I'm involving the nerve with some membranes of PRF that has growth factors, and has a coat. It will be a coat for the healing of the nerve, as you can see here. And then you can mix also the APRF plugs with some xenograph or autograph in this case, that is from the wall of that we removed. Because it's autologous bone, we use a bone mill, and we put it in chips or particles, and we mix with the PRF. And then we can use the IPRF if needed. And then we can put the bone wherever we need it, not only in the place that we open laterally in the window, but also in some place that we need. In this case, vestibulary to the mesial implant, we put some bone graft. You can see here we are suturing, in this case with the Supramid 4 zeros. I don't use silk. I prefer Supramid because we don't have a lot of plaque in the suture, and you can take the suture 15 days after with no problem. And we are doing the first session of laser therapy during the surgery, doing the traject of the nerve. Okay, and then ideally we should do 6 to 10 sessions between 2 to 2 days or 3 to 3 days to revert the paresthesia with a protocol that is with red and infrared laser that you can see in the slide. And of course, the infrared laser is more for biostimulation, and the red laser more for the healing. Okay. And of course, I do the protocol I told before with corticotherapy, PRF, vitamin B, ideally 2 months, but if you have recovery less than that, you will need to continue with the vitamin B and the low-level laser therapy. You can see here the X-ray immediately after the surgery. We are doing by cortical anchorage. We have bone all around the tip. It doesn't look here because it's a bidimensional X-ray. And the paresthesia in this patient after 2 days was just this small mapping that you are seeing in the slide. So this patient was quite a good recover. She took only 15 days to recover totally from the paresthesia. Normally it takes a little bit longer, but it depends on the patient, of course, and the conditions of the surgery. And then, of course, the teamwork is always the best work. I did the surgery, and then Dr. Pierluigi did the rehabilitation and also some soft tissue manipulation that I'm going to show. These were the provisionals done by Dr. Pierluigi. In this case, after 3 months, we waited for 3 months, okay, because we wanted the bone to heal a little bit. And we used some BOHPP. There are a special material that has some shock absorber behavior and acrylic crowns to do the provisionals. And this was a situation after using the provisional, was good but not perfect in terms of gingiva. So Dr. Pierluigi and me together, we decided to do some soft tissue manipulation. But also we did some checking of the occlusion of the provisionals with a specific tool that is called T-scan, that is the digital occlusion assessment. Because we are using the old-fashioned articulating paper, but nowadays we have much more predictable and objective ways of measuring the occlusion. So this T-scan is a digital occlusion analysis that has a software, and we can see not only the force that we are having the occlusion, but also the timing of the occlusion, and we can do the assessment and have great results in the long term. So this is the T-scan after putting the provisionals, but before adjusting the occlusion. Okay, you can see here that you have more occlusion, strength occlusion in the right side and posteriorly. And then after doing the adjustment, we have more balanced occlusion, and we don't have any strength on the provisionals. And also the occlusion is more centered, as you can see in the graphic. And here, sorry, it's the soft tissue augmentation with free gingival graft and also some vestibuloplasty. And the gum stayed much better. And this is the final result with a metallic ceramic crown. And this was something that we thought it was interesting after 2 years of having the rehabilitation done. We did a CBCT and after the nerve transposition, and we wanted to see if the bone was there and if everything was stable and how was the new mental foramina. And you can see here that the bone was quite well done, and that we had a new foramina that was well in the CBCT. So let's jump with some conclusions. Does anybody know what we are looking for? So normally in a presentation, I think it's important to take some home message and to be some clear and easy home messages. As a general home message of this lecture, I think nowadays with the new technologies and techniques, we can practice implantology in a more efficient, faster, and easy way. We know that. And we can use this in our favor. And some helpful new trends that we can use, there's some techniques like the ISQ, low-level laser therapy, the piezo T-scan, the CBCT, the PRF, or also some techniques like the palatal approach or the immediate loading when we have the right conditions to do it. We know that torque, we can only measure it once, and it's a rotational stability. ISQ we can measure several times and measure the axial stability. We can know that the bone density, we can measure it objectively in the TC and the CBCT in Hounsfield's units and can help us before going to surgery. And there's some rules for single implant and multiple implants for immediate folding, as you can see here. And we know that advanced implantology techniques have specific indications and high success. Also, as a general conclusion, I think if we should try a little bit better and try to go a little bit further every day. Because if you don't try, you will never know if you going to do it. So go a little bit further every day, and of course with the right education, but try to do it and try to achieve something more. The same, to be a little bit bold, to try to do something different, to try to think outside the box sometimes, because no guts, no glory, no legend, no story. So this is my contacts. I have a Facebook group called Follow the Red that is dedicated to surgery, that is free of access, and you can see and share a lot of information there. And then I have my LinkedIn page, my Instagram, and also my personal email. And if someone will have some questions or want to contact me, it's not so difficult with social media or by email to contact me. So thank you for this opportunity, namely to Dr. Kianosha for this invitation. And I really hope that this initiative of American Academy of Oral Surgery will continue, and we'll have more good events in the future. And ideally, that the events will be presential and not by online platforms. So thank you for everything. And I'm here if anyone has questions.